Bezans Healthcare apresenta Mulher Podcast. O seu podcast de saúde feminina, de médico para médico.
Hello everyone, welcome to our Mulher Podcast from Physician to Physician, the new podcast for gynecologists and obstetricians from all over Brazil. I am Dr. Marcela Mineiro, medical advisor of Bezans Healthcare, and I'll be your interviewer today. In this episode, we are back with Dr. Piette, the Pharm Scientific and Medical Affairs Consultant for Bezans Healthcare. And today we're going to talk about HRT. So, hi, Paul. Welcome back to our podcast. It is a really pleasure to have you here. Thank you for coming back.
Hi, Marcela.
As I mentioned before, today we are going to talk about hormone therapy in the Climatério period. But more specific than that, we will talk about the use of transdermal estradiol and natural progesterone. So, Paul, let's start with a tricky question. I don't know if this is the right word to describe this question, but what are the risks of using the manipulated hormones in the treatment of HRT symptoms?
So thank you for this very interesting question. Indeed, it's very important to know that manipulated hormones, even if they are natural hormones, can be very dangerous because they are not regulated by the agencies, and you never know which kind of hormone you will administrate, the dosing, and it was never confirmed as efficacious in rigorous clinical trials. So you have to be very cautious about manipulated hormones such as implants, for example, because you don't know the duration for the delivery of the estradiol into the blood flow, you don't know the clinical efficacy, and that's why we prefer to a body-identical hormone, definitely the hormones produced by the ovaries, for example, but they have to be regulated by the agency to know exactly the stability, the quantity, and the effectiveness of the formulation that you are prescribing.
Yeah, this is a problem. Yeah, isn't it? So when we talk about HRT, we are talking about, of course, both estradiol and, for the woman who still have uterus, progesterone. What can we say about the transdermal route for delivering the estradiol?
So it's crucial to determine which is the optimal route of administration. And all the scientific societies and guidelines emphasize the safety of the transdermal route of administration because you avoid what we call the first liver pass effect. That means that when you administrate the same dose of estradiol by the transdermal route of administration, the estradiol goes directly to the receptors in the body without going through the first liver passage. And we all know that estradiol, for example, such as alcohol, can be liver toxic when you administrate huge amount of estradiol by the oral route of administration. And the first liver pass metabolism will also induce a cascade of production of coagulation factors, for example, increasing the risk from thrombosis or venous thromboembolism, or it can increase, for example, SHBG, who will fix the testosterone and decrease the libido in women taking oral estrogen. So it's very important to take into consideration the route of administration, and transdermal route is the safest way to administrate the adequate dose of estradiol to alleviate the symptoms of postmenopausal women.
Yeah, it looks like that this transdermal route is the best choice for all women. Don't you agree? Not only for the patients that have obesity or metabolic syndrome, but for all women, transdermal estradiol is the best
Definitely. And in clinical practice, since the Women Health Initiative study was done in 2002, there was a clear trend to move from the oral intake of hormone replacement therapy to transdermal route of administration, which becomes the first intention treatment for all our postmenopausal women, because the benefit-risk ratio is favoring the transdermal route of administration versus the oral route, where you will have, in most of the cases, some unwanted side effects. And for sure, because you need to take this treatment for a long duration, it makes sense to have a first option as the safest treatment. And that's what you have by administrating transdermal hormones in association with micronized progesterone.
Yeah. And this is something that all the both international and national guidelines, they all agree.
Yes, there was a very recent statement by the North American Menopause Society published in 2022, highly recommending the transdermal route of administration for all those patients, not only the patient at risk, but just to have a safety profile and to have the optimal benefit-risk ratio for certainly long duration of treatment, because we all know that those menopausal women will beneficiate of the treatment if they take it for a long duration. There is no anymore arbitrary limitation in the duration of treatment at the condition that you initiate the treatment as soon as possible after the onset of menopause.
So let's talk about progesterone a little bit. Why use micronized natural progesterone and not other types of progestins during HRT?
Since the US study that I mentioned, the Women Health Initiative study, we all know that the type of progestogen is crucial for the safety profile of the treatment. And medroxyprogesterone acetate, which is a synthetic progestin used in the Women Health Initiative study, was inducing a lot of adverse events, an increase in breast cancer risk, of example, or an increase in venous thromboembolism or thrombotic stroke risk. So we all know that the choice of the progestin is important. And in that way, micronized progesterone was shown to be safe on the cardiovascular risk factors, such as myocardial infarction, venous thromboembolism, or stroke risk. And moreover, and that's probably the most important reason to think about micronized progesterone, was the breast cancer risk, because you know that even if breast cancer risk is a little bit increased in women taking HRT, we have now the reassurance that by giving micronized progesterone for at least 5 years or even 7 years, you don't increase the breast cancer risk in association with transdermal estradiol. So all very reassuring data since a couple of years, and now that we understand exactly what's happened with the Women Health Initiative study.
Okay. And is there any benefit to use micronized natural progesterone in the treatment of HRT in patients with a history of endometriosis?
But we all know that postmenopausal women will suffer lesser from endometriosis because they have no so much estradiol anymore, and we know that estradiol fuel the painful effect of endometriosis. So endometriosis is less a concern in menopausal women, but for sure in those women you will use preferentially micronized progesterone because it's a fantastic anti-inflammatory hormone. We know from all our studies in pregnancy that the key role of progesterone is to have an anti-inflammatory effect. And in this way, those women with a history of endometriosis will beneficiate from this natural progesterone instead of using synthetic progestogens.
Yeah. And Paul, I have one final question to you. What can you say about the fear of HRT that some physicians and, of course, some women still have?
We know now that the increased risk of breast cancer is very limited, and it can be observed when you use synthetic hormones or if you use the oral route of administration. But we know now that based on several observational studies done in Europe and in the UK, that by administrating transdermal estradiol and micronized progesterone, you don't increase the breast cancer risk in those women, at least if you initiate the treatment in the early menopause, and you can take the treatment highly safely for more than 5 to 8 years. So very reassuring data versus the study that was done in the US in 2000, and where the breast cancer risk was increased by using synthetic hormones.
Yeah, so it really looks like that when well indicated, the HRT can improve health and, of course, the quality of life of the climateric women.
And that's definitely the major reason to believe in hormone replacement therapy. When you ask clinicians what they think about hormone replacement therapy, they will immediately confirm that the quality of life, the prevention of osteoporosis, and the decrease in cardiovascular risk is, let's say, highly significant when a woman takes some measure, for example, to do physical exercise, to not have too much weight increase, and that's probably the most important, to take hormone replacement therapy.
Yeah. So unfortunately, we come to the end of this episode. And I would like to thank you, Paul, very much for this outstanding interview. And I hope we can see each other soon. Thank you very much.
Thank you, Marcela.
Okay. Bye-bye.
Bye.